So over to Dr. Suven, please.
Thank you, Dr. Minu, for this invitation. A wonderful course, and even on the last day, we have a reasonable crowd. Actually, in other venues, we had much higher crowd. So I'll be speaking. I'm Suven Bhattacharjee. I'll be speaking on capsular access instrumentation and techniques. No financial interest. Now, this is the first tool that you require. I am very much a needle person, so with the bevel up, we bend the needle tip just vertically down 90 degrees, then bend at the hub. This is a two bend. Now, you could do a third bend, which I prefer to these days, is bend it in the middle. Now, that brings it to what is called a three bend system. So, you have a two bend system and a three bend system. Now, how does it offer an advantage? Is when you have a two bend system, there is a chance that while doing the capsular access, you will be pressing the posterior lip and your viscoelastic is going to escape and your AC is going to shallow, and that will lead to complications. So with the three bend system, what you do is you are not pushing on the posterior lip, you are it's actually directed towards the anterior lip, so the wound does not open up. Now, of course, the capsular access forceps, the good old Uretrata is now probably out of use. Now, mostly we have the Haldipurkar forceps, a wonderful invention, definitely. Now, I will not talk about much about canal capsulotomy because I don't have a video of a can opener, because it's been a long time. This is borrowed from Minu. I think Sudeep showed some wonderful can opener videos. Let's see a standard capsular access. So, the ideal visco OVD would be injecting a cohesive one, a dispersive one, followed by a cohesive one to flatten the dispersive onto the endothelium. And of course, the cohesive one gives you space and flattens the anterior capsule. Now, these are standard, all of you, I'm sure if you're in this hall, you are already doing capsular access. So now, this is in one go without any visco top-up. That's ideal if you can get away with it, perfectly all right, but no shame or harm in topping up viscoelastic. Now, this is where I thought there will be a little bit of a struggle. So what I did was I wanted to top it up. So just keeping my needle right over there, I top up the visco till the capsular access flap is flattened onto the rest of the capsule. So now everything is under control, and you can go ahead and you can do this top up as many times as you want, depending upon the size of rhexis you want, how you want to control the rhexis. There is no shame. What I'm trying to say, just stabilize your hand. If you feel that it's not stable, just hold it with two hands and inject that viscoelastic. Now, this is a principle which you have to understand. This is a very important take-home message. If you're injecting cohesive viscoelastic during initiation of rhexis, the purpose is to inject it in the center so that you flatten the anterior capsule. The purpose is you flatten the dome, the tear does not run downhill. Zonular forces are neutralized. Now, if you have got this part, so when you have a runaway capsular rhexis, you do not inject in the center. When you inject in the center, what you have is you're pushing the loose cortical matter from the center to the sides to result in a donut. Your runaway rhexis is going to run faster. So what you need to do is now inject that cohesive viscoelastic at the leading part of the tear. So that is where you flatten it and you oppose the radial zonular forces. That's when you have control, and you will see it works wonderfully. This is something which I want everyone again to know. This is going to rescue you and the capsular rhexis. So, Little's capsular rhexis. I would highly recommend that each one of you reads this original article. So to rescue the capsular rhexis, the tear must be directed centrally and back to the desired circumferential path.
Yes.
Force applied to the capsular flap is then reversed in direction but maintained in the plane of the anterior capsule. Very important. Reversed in direction but maintained in the plane of the anterior capsule. First, unfold the capsule flap so that it lies flat against the lens cortex as it did prior to being torn. So let's see the images from the original publication. Brian Little, a great person, has really done commendable work. So switch to forceps if possible. Hold the flap as close as possible to the root of the tear and pull circumferentially backwards in the plane of the capsule. See that? When you then holding the flap under tension directed more centrally to initiate the tear will predictably propagate to the center of the capsule. Now, this is something which I would like to demonstrate over here. You can go back home and try this. There are two forces which I applied in capsular rhexis, the tear by stretching and the tear by shearing. So when we are using a needle or a capsule forceps to tear, it's mostly shearing. It's this, right? Now, if this is my right hand, I want to now, my capsule is running away. This is my stable part, the peripheral part of the capsule, and this is my leading the capsule. So I have done this, I have now flattened it, and I pull. It is going to come this way. You can do this again. Sorry, this is a little too much. Go back home and try it. It moves very predictably every time. So if you're doing this, now you hold this, keep this stable, see which direction it goes. It moves towards my hand. So you pull it in the plane, it moves in that direction. And that's something you can practice at home, and once you gain actually it feels a little scary. You feel that it will go out, but it always turns back. So now let's see this. This is a situation where I actually applied the little capsular rhexis twice. Now there's a little bit of fibrosis over here. So I was struggling, and that capsular rhexis would not extend. So I used a pair of scissors to make a nick, to progress a little. So there I made a nick, and I am progressing. And that's when, after that, the first pull, and that gets a little uncontrolled. See, now there it is now already heading outwards with a fibrosis that could get messy. So I am now going to try the little's maneuver and see what I'm doing. I'm pulling it in the direction, in the same plane. Not good enough. Go closer to the leading part. Hold that there and pull. And there it moves towards the center. Now I can control that rhexis and go ahead. Now again, there I am, again doing that. Okay, now I come back and do this capsular rhexis, and I'm almost 3/4 done, and when again I feel that it's going to run away. Hold it by the ear and pull it back, that's it. Yeah, so now that's the place where it's going to start running. There. So now I'm going to just hold that and give it that tug, sharp tug. You see how it moves. It moves wonderfully. You have full control. And I'll show you time and again. This one I'll have to little advance it probably. Yeah, so this was where I was going fine, and somewhere towards the end here. Here again I'm going to struggle a little bit. It's going to run, and this intimation cataracts can be there. It is going to now run. There. It started running, so I now give it a tug. I just change the direction, and there it is. It's very, very predictable. Now let's capsular rhexis during phaco. Now this started off well, and now I have caused, my chopper has caused a tear at 6 o'clock, if you can see. So now I have to control this. I do not want to go ahead with my chopping with this in place. So I'm going to now hold that, and there, get a good grip, and I'm going to turn that. There you are. Now I can go ahead with my chopping and do whatever I want. So at any point when I see that my capsular rhexis is damaged, I can go ahead and rescue it. Okay, and that's where it looks like a keyhole. That's all right. My lens is in the bag. It's perfectly centered, you see. So now this is little rhexis after phaco. I have still got a little bit of cortex over there, and I notice now that place over here, there is a problem. You see there is a little problem. So I want to tear it. Yeah, I'm doing finishing. So now I try tearing it from this side. Not much of help. I'm not getting purchase. I really don't. It will be a shame if I spoil this case. So now what I do, I create a nick, and now I try little's rhexis. Create that nick, and I'm not going to use my shearing forces. I'm going to use stretch. See that? And I'm going to do that, and there. I included that radial stretch that was there. So that's about all. Thank you very much for your attention.